So let me show you a situation that we encountered where this patient had originally come to me several years prior to this appointment with inflammation around tooth number 9. Radiographically, there was nothing remarkable. The tooth was not mobile, and we performed an initial therapy of scaling and root planing on this patient, and she disappeared for follow-up. We were never able to reevaluate her until she came back with a severe abscess and some gingival recession. And now the tooth had a great deal of mobility. And prior to performing immediate tooth replacement therapy, we performed a laser assisted debridement just to reduce the amount of microbes subgingivally, try to improve the tissue tone to some degree before going back about 10 days later to perform an immediate tooth replacement therapy. She was unwilling to go with a flipper if at all necessary. And so here we're placing, at the time of extraction, this novel implant, an inverted body shift implant here where we're wider in the apical 50 to 60% with aggressive threads designed for primary engagement of that cancellous bone, apical and palatal to an extraction. And we have a 12-degree subcrestal angle correction within the implant. So here we have the opportunity in most cases to place a screw-retained provisional restoration with the screw channel exiting through the cingulum. And so here we achieve a high level of insertion torque of 75 Newton centimeters and a very high initial ISQ value of 72 taken from the buccal and the palatal. We then go on to perform our dermal apron technique with our dual zone graft. Here the apron is relatively long because remember we lost the spatial plate. And so this is now serving our apron as not only a soft tissue graft for thickening that mucosa, but also as a barrier to contain our bone graft and serve in a GBR fashion. So this is really the dual function of the dermal allograft. And I contemplated at this point also adding a subepithelial connective tissue graft, but I felt the patient had enough surgery for one day, and she was made aware that we may have to go back and do a corrective mucogingival procedure. But this temporary restoration is out of occlusion and is very tight and secured to the implant. This is 3 months healing. And at this point, one, I'm not feeling the need to do any kind of additional mucogingival surgery. Here we have nice, thick, soft tissue, no recession, and we have an increase in ISQ of a couple clicks, up to 74 and 75 from 72. So we know this implant is osseointegrated. We can refer her back to her dentist, and when he disconnects the provisional restoration, we see a little bleeding, which we know from Hanai Saito's work is actually a good thing because we have epithelial attachment to the provisional abutment and restoration, which sealed off that bone chamber for osseointegration. And we have thick, robust, soft tissue. So a screw-retained final restoration can be placed to replace this tooth. And we didn't have to go to the palate. And because we achieved such a high level of primary stability right out of the gate, we had confidence going all the way through treatment.